brought to you through academic grant from the makers of Azithral. A few rules. If you are to speak, please ask for the mic and speak into the mic. I know once the clinic starts and we get into the flow and we get into the excitement, we tend to jump up and just talk. The online audience can't hear you, so please use a mic before, ask for a mic before you want to say anything. We begin with our first case. Dr. Anita will be presenting it. Dr. Anita.
Good evening. My patient Akanksha is a 4 years old female child, third by birth order of 4 siblings, born of non-consanguineous marriage, Hindu by religion, Mahar by community, residing at Vittalwadi and hailing from Solapur. She is brought by an informant being father with the chief complaint of abdominal distension since 4 months, fever on and off since 15 days, and yellowish discoloration of eyes and urine since 15 days. Patient was apparently all right 4 months back when she developed abdominal distension, which was insidious in onset, gradually progressive in nature, mostly involving the upper part of the abdomen, which gradually progressed to involve the whole abdomen, which is not associated with any bowel bladder complaints, not associated with pain abdomen or respiratory distress. There was history of fever on and off, which was of moderate to high grade, intermittent in nature, not associated with chills or rigors, not associated with rash, and responding temporarily to oral medication. The child was active during the interfebrile period. Parents also noticed yellowish discoloration of eyes and passing of dark colored urine since 15 days, which was, and the yellowish discoloration of eyes was gradually increasing in intensity. Parents also give history of increased paleness, which is noticed by the parents as compared to that of the other siblings since the last 15 days. For the above complaints, patient was shown to a private practitioner, mainly the Ayurvedic doctor, and has taken some medications. There is no history of passing clay-colored stools or pruritus, no history of pedal edema, swelling of the face or breathlessness, no history of altered sensorium or sleep pattern, lethargy, nausea, vomiting, or abdominal pain, no history of skin rash or joint pains, no history of bleeding from any site of the body, no history of receiving any PRC transfusions in the past. I would like to tell a significant family history of, in the father there is history of recurrent jaundice since 15 years of age. There was history of jaundice every yearly, and the father has been taking some Ayurvedic treatment since 15 years of age, since 15 years of age. Birth history, the child is nothing significant. There was no history of any neonatal complications or postnatal complications. It was a full-term vaginal delivery. Birth weight was 4.5 kg. Immunization history is completed till date as per the universal immunization program. Developmental history, the child studies in senior KG and she is average in the scholastic performance and developmentally appropriate for the age. Dietary history, the expected calorie for her is 1200 and she has a deficit of 300 kilocalories. Family history, she belongs to, the family belongs to upper middle class according to the modified Kupuswamy classification.
So what do you make out of the chief complaints? The first complaint is abdominal distension for the last 4 months. So what do you make out of that?
There was history of gradual abdominal distension which was gradual in onset and progressive in nature. So could be suggestive of any organomegaly.
Yeah.
Could be suggestive of organomegaly.
Only organomegaly. So let's go systematically. What are the possibilities and how do you rule in or rule out some possibilities? So what else can give you abdominal distension? It could be fluid as well.
Fluid in the abdomen.
What else?
Fluid in the abdomen or any gaseous distension can give rise to abdominal distension, organomegaly.
What else?
Any hollow viscera which is involved.
So any mass besides organomegaly?
Can give rise to.
Yeah? Okay, then?
It usually presents as a lump, not to generalized distension, so if any mass.
Okay, what else? So take one by one now. You said organomegaly or mass, that will put in, let's say, one category, then fluid is another, then gas is a third category. Would simple hypotonia of the abdominal wall
Pot belly.
yeah, so that's muscular distension or hypotonia, that's another category. And obviously feces, so constipation, chronic constipation, fetus is out in children, so 5 F's when we talk of. So now take one by one and tell me which one do you think this is likely. You said organomegaly, so tell me why you want to not consider the others or rule out others.
So, pot belly, like in the case of hypotonia, it is not progressive in nature.
Okay, and one point is it will not be progressive. What else? Anybody?
Upper abdomen will not be involved differentially. The entire abdominal distension has to be there.
Okay, so it should be entire abdominal distension and not just upper abdomen. Now we've discussed this. This history of upper abdominal will sometimes be very accurate with parents, sometimes depends on how intelligently the parents observe it. But yes, that's a point. Anything else you wanted to say something?
Sir, it will be more like obvious on standing, and on supine position it will decrease or resolve.
Very good. So essentially what he is trying to say is that abdominal distension which is due to hypotonia will be waxing and waning, either with position or after food or different times of the day, etc. Okay, so these are the 3-4 reasons why this is not just hypotonia of the abdominal wall. What else? Why is it not chronic constipation of feces? So
Again,
did we ask history of constipation?
no history of any bowel bladder complaints. No
Okay.
history of constipation.
Okay. So at this point, just make it a point to remember that history of constipation is not easily forthcoming in little bigger children. You have to dig into the history because the parents may not know. You have to ask them, does the child, how frequently the child visits the washroom. Taking a long time in the washroom could also be constipation. Coming back quickly in 2 minutes and going 3 times a day could also be constipation. So you need to dig hard into that. Okay, what else? So why not fluid? Yeah,
Fluid.
anybody else?
So fluid, the dynamics after a particular time, it will stop, the abdomen will stop getting enlarged.
Yeah, but that is relative because it will stop after 10 days.
Yeah, but
It's
here
still in the growing
history
phase.
is like 4 months.
Yeah,
It's
so it will
progressively-
stop at 4 months, 15 days. You're right, but okay, and any other points?
So any history of collection of fluid at any other site, periorbital edema, pedal edema,
Okay.
or vulval edema,
Yeah.
decrease urinary output.
Yeah. So edema at other sites or history of swelling at any other sites is not there. So if at all fluid, then it is localized to the abdominal cavity. That's one. And then what are the points for or against? If it is fluid, first point is very valid, that because it is not there at other sites, it's, if at all it is fluid, it is localized to the abdominal cavity. What else? So where do you get fluid in the abdominal cavity? Where do you get fluid only localized to the abdominal cavity? And then how will you rule that out or rule that in?
Usually fluid in the abdominal cavity is suggestive of some liver pathology, which might be having other signs of liver pathology. Like actually, usually fluid accumulation occurs in end stage, might be an end stage of liver disease, so it might be associated with other signs of liver cell failure or something.
Okay. So what she's trying to say is that if it is a liver pathology, fluid accumulation suggests decompensation of liver, which means liver disease has been there for some time. So we may get a history of that. So therefore it's very important here to ask whether this child was absolutely alright 4 months back. Whether this child was absolutely active, playful, and there were absolutely no complaints. Did you ask that?
Yes, sir.
Okay. So that's one point. What else? Can it be just say tuberculous ascites, that is fluid in the abdomen?
There was no history of COX or COX contact.
Which may not be there, but which may not rule out tuberculosis just because there is no history. So what do you think? Can it be tuberculous ascites, an example of fluid in the abdomen?
Fluid again will not have such a differential. It will be more localized towards the flanks or the lower abdomen. One. Second, it will again have a diurnal variation. It may have a positional variation. On supine position, it may seem to be reduced in intensity. All these go against fluid, and being a generalized distension will go more towards the fluid, and a localized or upper abdominal, a zonal, a quadrant-wise distension goes more towards an organomegaly.
See, all these observations about flank more distended and in standing position and all, these are observations which a doctor will make. You won't get all these observations so accurately on the history. So besides that, as I am giving you a specific example of tuberculosis.
History of loss of weight, loss of appetite.
Okay, so absence of constitutional symptoms. However, tuberculous collection of fluid can often be in a child with a good immunity, a good host. So you may not have constitutional symptoms. So what is the point against in this child, specifically for this reason?
Associated history of icterus.
Forget the icterus. Suppose the icterus has not yet come.
Sir, the child will be sick.
Not necessary. We said no, good immunity, good host, so not necessarily a sick child. Come on, anybody? Simple, na? You said that this was progressive over the last 4 months. Tuberculous ascites will not be progressive, no, over the last 4 months, right? It will come up and then just be there. It can't just go on progressing gradually over 4 months, right? So that's one reason, one more reason against that. So when you are answering whether this could be fluid or not, what you would have said is that the common conditions associated with fluid in the abdomen would have many other manifestations. So liver disease we already discussed. Similarly, a nephrotic would have generalized edema. Similarly, a child with cardiac problems would have many other complaints much before fluid in the abdomen. And then there are causes which are localized, like say tuberculous ascites or let's say pancreatitis. Why can't it be pancreatitis?
Severe pain abdomen.
Okay, and?
Not of 4-month duration, sir. Acute.
Okay, so usually it's an acute situation. What else? On history we don't know, but usually it's a very sick child. So these are the reasons why you think this is likely to be organomegaly. Okay. What about a tumor or a mass?
Yes, they usually present as a lump in the abdomen, not as a...
One. What else?
Rajesh, one sec. There's a question about tuberculous ascites. Is it progressive if it's not treated? Will it keep expanding in size if you don't treat it? That is the question which has come.
Yeah. So actually hypersensitivity phenomenon, if it happens as a hypersensitivity phenomenon, it will be sudden, acute, and then I think it will just establish equilibrium and it will just stay there. Whereas if it is seeding of the peritoneum due to a disseminated disease or a contiguous disease, then you will not get a huge ascites anyway.
But one contention is that we say that exudative or inflammatory edema, inflammatory ascites is progressive and can increase. So that's one of the things.
I think when tuberculous peritonitis occurs, largely it's an immune-mediated disorder. Largely it's an immune-mediated disorder. So it can go on increasing. But what happens is that as the disease progresses, there is an immune suppression. He can't go on developing immune response. After all, an immune response starts when he is fit. Now he is not treated. So the disease goes on worsening, and as the time goes, he will start getting immunosuppression, and therefore he will not progress with immune inflammation. You get what I mean? So there is a limit to which, but suppose a point that Amol made, that the ascites will not go on increasing, is not totally true. For example, a malignancy can just go on increasing, but there will be a limit. a malignancy go on increasing will even end up fatally. It can't just go on increasing. And a tuberculous peritonitis go on increasing, which means the tuberculous organisms are now more and more multiplying, will cause an immune suppression. After all, a serious tuberculous ongoing disease suppresses immune mechanism. That's why in a serious forms of TB, MAN2 is often negative. Okay, disseminated form, a miliary TB, okay, MAN2 is negative. And as soon as you start treatment, a MAN2 becomes positive. That means an immunosuppressed state was due to a disease, and when the disease gets treated, immunosuppressed state turns into an immunocompetent state. So that's why a tuberculous peritonitis may not go on increasing, but yes, to begin with it will go on increasing, but there will be a limit beyond which it will not increase. So that's when it comes to 4 months, therefore, we know for certain that gradually increasing abdominal distension cannot be ascites till proved otherwise. And the reason is exactly this, that if it's a transudate, it will be at many places. If it's a portal hypertension and cirrhosis, oh, it will not go on because the liver is failing already. So the child will go down and not have a distension for 4 months. And then if it is a malignancy, it will not stand for a long time. He will get more and more sick. And if it's tuberculosis, he will start getting immunocompromised. So he will start forming less and less fluid. Unlike in a tuberculous pleural effusion, where there is no time, a sudden increase in fluid makes a child come breathless. In abdomen, it doesn't come. That's the reason I suppose this is.
So one exception for this would be pancreatic ascites?
Absolutely. And that also will not go on for a long time, as we said, because he is a very sick child. And therefore he comes as a very fastly progressive sick ascites.
So we have decided that this looks like organomegaly on history. That's about the abdominal distension.
See, the discussion that we are having is, if you did not know jaundice, how would you have looked at abdominal distension? When the whole story is told for 4 months, don't forget that one day this child was only 1 day illness. Could we have picked it up at that time and said, oh, he is going in for something different? That is the fun of clinical medicine. When he comes after 4 months, even a grandmother knows what the problem is. And she has not gone to school. Why are we wasting time to go to medical school to learn that? So we should be one up. And we want to pick up this as a liver disease before jaundice comes. After all, when jaundice comes, everybody knows it's a liver disease. So our discussion in this clinic is not entirely the whole story. The whole story comes at the end of absolute clear picture. Then it's a theoretical discussion, what liver disease, etc. That will do. But the fun is, what you would have made on day 1, could you have said this will happen in after 4 months? And I think that's what we need to learn.
Now, I was not very clear about your second complaint of fever. So, is the fever for the last 4 months off and on, or 15 days off and on?
15 days.
So, if we discount the last 15 days, then for 3.5 months, there is only one complaint of progressive abdominal distension.
Yes, sir.
And which we have narrowed it down to organomegaly,
Yes.
most likely. So now, how do you look at 3.5 months of progressive organomegaly in a 4-year-old apparently healthy child to begin with? What are your thoughts? So what is this category of organomegaly, and then we'll take it further. Anybody wants to think and talk? 4-year-old child, bang normal to begin with, and 3.5 months of gradually progressive abdominal distension. Come on, some thoughts on what are the classes of groups that you would think of.
It could be hemolytic,
Okay, why do you say so?
gradually progressing organomegaly, and in a 4-year-old child could be a manifestation of any hemolytic diseases.
Okay, fine. So now various questions. What should a hemolytic disease present with ideally?
Increased paleness or
Okay. So
present with severe anemia.
okay, so that is there in this child on direct questioning. You got it, or
On inquiry, they noticed increased paleness.
okay. So on inquiry, they did notice increased paleness. Okay. What else? What are the other histories that you should have got? And then what are the other possibilities?
History of PRC transfusions in the past, which is not there in.
Okay,
this
but is
child.
it a must?
It could be the first manifestation.
Okay. So which hemolytic anemias can present for the first time at 4 years of age as progressive abdominal distension?
Thank.
Enzyme deficiencies, G6PD or thal intermediate.
Why G6PD as hepatosplenomegaly? No. So hepatosplenomegaly, not G6PD.
Hereditary spherocytosis.
Okay. So hereditary spherocytosis usually presents as what?
Jaundice.
Okay. And or is it hepatosplenomegaly? Splenomegaly, in which case it's not usually abdominal distension, because as we all know, abdominal distension and organomegaly means hepatomegaly is a must. Okay. So thal intermedia you said. Okay. Would you get some more history about thal intermedia? Would thal intermedia first start getting abdominal distension at 4 years of age? And any other history? So what is our concept of thal intermedia? What is thal intermedia? Anybody?
History.
Anybody else wants to speak? Okay.
Family history would be there.
Okay, so there should be a family history. What else? What is our concept of thal intermedia? What does it mean?
Heterozygous.
B globin chain partially synthesis, partially not, categorized as thalassemia intermedia.
So clinically, how would you call it? How would you describe it? Is it a thal major or is it a thal minor? So how will you describe it clinically? So you should look at it like a thal major with comparatively reduced transfusion requirements, because the globin chain synthesis is not that badly affected. Okay. Now therefore there will be a big spectrum. So maybe you can get hepatosplenomegaly at 4 years, but what I thought is this is too fast presentation, meaning if the history is right that till 4 years this child was absolutely fine and then suddenly last 4 months progressive abdominal distension, I thought that was a bit odd. Okay. Any other hemolytic anemias that can come at this age? Yeah.
Apart from anemia, it could be a chronic infection like malaria.
We'll come to other categories. Since she brought up the anemia, we'll finish this and come to other categories. So any other hemolytic anemias are you thinking of? Okay, fine. So okay, now you said infection. So tell me about infections.
Sir, bacterial infection could be there, like tuberculosis, or in parasitic there could be malaria or kala azar, and leptospirosis, but is unlikely.
So will all these conditions present with just abdominal distension for 3.5 months?
Sir, kala azar could be there, chronic kala azar infection could be there, or chronic malaria.
So without any other symptoms?
No, associated with other
Which other
GI
symptoms?
symptoms, like in case of kala azar there could be a gastric upset like nausea, vomiting, or like
What else happens in Kala Azar? Do they eat well?
no sir,
Sick
appetite
child, weight loss.
appetite decrease.
So are all those symptoms here in this child?
No.
You've asked for history of all that. So there's no history of loss of appetite, there's no history of weight loss, there's no history of fever, there is no history of, you were talking of malaria, so no history of fever, no history of, you're talking of infections. So again, there's no history at all, no other history.
History of fever only since 15 days.
Yeah.
So could, apart from infection, I would like to jump to other category, like malignancy.
Yes.
Leukemia could be there because of progressive as well as the fever for 15 days. But as she said, there is no.
We are still before the fever.
Okay.
Then we'll come to the fever and then try and connect the fever. So right now we are at a stage of 3.5 months of progressive abdominal distension with apparently no other complaints in a 4-year-old child. So let me
Rajesh, before we go to malignancy, even for us to consider infection, I think our chief complaint should have been fever.
Exactly,
If
that's
it is
what we
not there,
discussed.
then we just don't
Yeah,
consider
yeah.
that at all.
Yeah.
And just one more announcement, those of you who are having problem with live streaming, the problem is just refresh your browser, because there's no problem from this end. It's your connectivity issue which is causing these issues.
So just to put this thing in a proper context, when we said organomegaly, we said which means hepatomegaly is a must because there's abdominal distension. So when you are thinking of hepatomegaly, how would you group the disease into 4 parts? So which are the anatomical 4 parts of the liver that you will consider to have got involved? Anatomically, liver disease can be divided into 4 anatomical parts. Which are those?
Parenchymal,
Parenchyma or hepatocyte disease, very good.
biliary tract,
Biliary tract, very good.
reticuloendothelial system,
Reticuloendothelial system,
and the venous and
very good. Venous system of the liver, very good. So now out of these 4, in this child with this kind of a history of 3.5 months of only distension, which do you think is likely?
it could be parenchymal.
So in parenchymal liver disease, what are the other indicators of parenchymal liver disease?
Any synthetic functions which could be involved,
Like,
hypoalbuminemia causing
so,
generalized distension,
or fluid in the abdomen or edema. So we discussed that this doesn't look like fluid. What else? There's no history of edema.
Their excretory functions could be
Like,
bleeding, that
yeah, excretory functions,
like bilirubin, so icterus manifestation.
okay, which is not yet there. Then
bleeding from any side.
bleeding from any site would be a manifestation of synthetic dysfunction. Okay, what else?
And then any altered sensorium and all, there's no history, so excretory function like
Okay, altered sensorium will be in a end stage. So can you tell me what is the symptom of acute hepatocyte disease? Jaundice, right? Acute hepatocyte disease, anorexia, loss of appetite, jaundice. And chronic hepatocyte disease is when it gets decompensated, ascites. Otherwise, failure to thrive, growth failure. Okay, so these don't seem to be there here if our history is correct. So that means hepatocyte disease less likely. Venous system disease,
it presents with sudden onset or acute onset of abdominal distensions.
so abdominal distension due to fluid and with maybe edema or no edema.
With here there is no edema, with it presents with edema usually.
No, so depends. Venous system disease means if you are talking of a Budd-Chiari prototype, then you will get ascites and hepatomegaly. Okay, okay. Then third category is a biliary tract. Biliary tract must have jaundice. So if we analyze this till 3.5 months, and if our history is correct, then this seems to be asymptomatic hepatosplenomegaly without any other symptoms. So you come to reticuloendothelial system, and then you come to all these categories which cause involvement of reticuloendothelial system, like hematological you said, then you said infection, then malignancy, and then we discussed the pros and cons for all those reticuloendothelial involvement. Okay. Now this child has come with last 15 days fever and icterus. So now we want some details of the fever and of the icterus, and then let's see where we stand.
Fever was of moderate to high grade in nature, intermittent type, not associated with chills or rigors, responding temporarily to oral medications. And the child was active in the interfebrile period.
So now off and on you said, or intermittent means, but 15 days, so each day?
Not each day, no, with intervening of 2 days in between, as the father has told, like reduced on medications to recover again after 1 or 2 days.
So that means this in 15 days maybe this child has got 5 or 7 episodes of fever. Yeah. So what do you make out of that? High grade or moderate?
Moderate to high grade. He said 102. He has measured the father 102 degree Fahrenheit.
So what do you make out of that? 5 to 7 episodes of fever in 15 days, moderately high, interfebrile, playful, normal. So just general thoughts. Can it be a viral infection? Can it be a bacterial infection? Is it not an infection at all? Can it be a parasitic infection? He was talking of malignancy. So is it a leukemia with a fever coming up now? Initially hepatosplenomegaly. Any thoughts on that? Come on, let's just start guessing or thinking, not guessing, thinking logically. We have discussed fever so many times.
Am I allowed to answer?
You tell us. What do you think of this fever?
Could be viral illness.
Okay. Why do you say so?
Because it was, first of all, on and off. Then the child was active in the interfebrile period. So bacterial, there was not like a sick child.
Okay. So what you are saying?
I think at this point of time, let's not forget that we have a hepatosplenomegaly. Now you relate the fever only to that. Which asymptomatic liver and or spleen starts causing fever at the end of 3.5 months. So don't discuss causes of fever. Discuss the probable cause of fever in a child who has had 3.5 months of an asymptomatic liver and or spleen. We still don't know whether it's a liver, spleen, or both, or one. So you discuss that could it be only liver and now he gets fever. What must that be? Could it be only spleen and now he gets fever? Or could it be both and now he gets fever? So think about how you connect fever, and if you cannot connect, then accept that it is unrelated condition. But before you call it unrelated, you must try to relate it first. So we will start thinking, could it be only spleen and now he gets fever? Could it be only liver and now he gets fever? You get my point? That, I think, is the problem in this child. So how do you look at that? And look at the third possibility. Has the low-grade fever missed in this child by the parents? And now that low-grade fever has become high. So keep all possibilities open, because it's easy to miss a low-grade fever. So first I want to know that at 3.5 months of asymptomatic, you said, abdominal distension, has he been doing very well during these 3.5 months? Or he is already getting sick? If he is already getting sick, then it's not a silent liver and spleen. It's already causing trouble. That's most important. But if you say, oh, he gained another kilo in this last 3.5 months, I would even ask you whether that kilo came from a liver and spleen. So that only gain in weight also is not my issue. How happy he was, how playful he was, how well eating he was. And if you convince me that he was a normal child, then I would say it could be a coincidental, unrelated fever. But if he was never all right, then I take him as a sick child right from beginning, a sickness heightened at the end of 3.5 months. And that's where you start saying, oh, he has got fever now. You get this point? So let somebody start thinking. We are wildly thinking. The whole idea of our clinic is to make you think. Okay, the rest is we will read and get knowledge. But many have a knowledge who don't think and therefore they can't put it. So we are trying to make us think. So who will take this? Start with anything. Okay, you want to say he was... So do you know whether he was sick or not sick during 3.5 months? So we need to ask all this. Okay, if you have not asked, doesn't matter. You have learned that you could have asked. That's okay. Okay. Which is the most important part? What have we said every time? Origin, duration, progress. Progress. Not progress of abdominal distension only. Progress of his health. Is he doing well or is not doing well? Yeah.
So she has asked and the child is not sick.
Child is?
Sick in 3.5 months.
So I need to be very sure. If you say child was not sick, may not mean good. Okay. So I want to know whether he was as good as he was before. Now these things need to be asked up front. Okay. And if you ask that, then I would say it was an unrelated fever. Because nothing that keeps him so frail, inner liver and spleen disease becomes febrile now. We have said most of the diseases start with fever. Why is he getting fever now? So that's not right. So I think you should look at that, right?
Okay, what about the jaundice?
The parents have noticed yellowish discoloration of eyes and passing dark colored urine since the past 15 days.
Okay.
Not associated with clay colored stools or any itching.
Okay. So, again, how did this jaundice start? Are some more questions important there? See, we have to, as Sir said, we have to take it as a child with hepatosplenomegaly or hepatomegaly, whatever, presumed, who now gets jaundice. So now, if we are towing the line that this child was otherwise absolutely fine, then he gets jaundice now, then it's little bit of a surprise and therefore it's an unrelated thing, as Sir said. So what questions you want to ask, and if it is related, then what questions?
That whether it was of mild grade from the onset, like from the past, and now the intensity has been increased over the past 15 days.
Okay, but that though he told you that there was no jaundice earlier. What else?
Don't you want to know whether it's an indirect bilirubin or a direct bilirubin by history?
Yes.
First,
She's
pick
saying,
up that.
sir, she's saying high colored urine.
Yeah. So that you are sure of.
Yes.
So it is a direct bilirubin. All right.
What I'm trying to ask is, are there any prodromal symptoms or anything like nausea, vomiting, loss of appetite?
No history of nausea, vomiting, loss of appetite, but in fact the father gives history of increased appetite, but I couldn't relate it to this history. So
Okay. So there is history of increased appetite. Okay. Fine.
These diseases have increased appetite. No, there are diseases with increased appetite. So, if you really say increase, many times the increase is really earlier decrease which has come back to normal. That is increased. Okay. But if you really say now he has a voracious eating, like a child on steroid therapy has an increased appetite. Is that kind of an increased appetite? Or she is eating a little better now, earlier she was not eating, so it's increased. Increase is a relative term. So make sure. But is there any disease that has increased appetite? But that's a funny statement, increased appetite.
Endocrine problem like thyroid, hypothyroidism has increased appetite.
Okay. Any other endocrine problem that has?
Cushing syndrome.
Okay, Cushing's. Then any other endocrine?
Functional disorders may also have an increased appetite.
Okay, functional disorders.
What about diabetes? Yeah. polyuria, polydipsia, carbohydrate deprivation. Those who don't take carbohydrates may be really wanting to have more if you're deprived on carbohydrates. And therefore, a low carb now is because of very high protein that you suppress your appetite. But if you have a normal protein, normal fat and low carbohydrates, you're craving for it. That's a carbohydrate deprivation. Whereas here, you take lot of proteins and lot of fat, low carb, that you lose weight. So there are two things. Low carb is a purposeful, imbalanced diet, whereas a carbohydrate deprivation is really normal protein, normal fat and much less carbohydrate. They want more and more things.
Rajesh,
Then of course, yeah.
there is one hypothesis floated here. Will you entertain that? A viral fever like Epstein-Barr virus causing hepatosplenomegaly, followed by neutropenia because of hypersplenism causing bacterial infection.
Yeah.
I know it's a long story, but if you could
So
just-
first of all, the Epstein-Barr which starts, it has to start with fever and not with just hepatosplenomegaly. Then hypersplenism, when it leads to any cell line depletion, usually clinical functional effects of those cell line depletion are not seen, be it neutropenia or thrombocytopenia. Occasionally a hemolytic anemia which gets into hypersplenism may show anemia which is aggravated, but otherwise not. And therefore, getting a bacterial infection due to that neutropenia is out.
And an EB virus disease has a hepatomegaly because of hepatitis. It is not without hepatitis.
It's not a reticuloendothelial
So
enlargement.
EB virus is hepatitis. So
comments on a 4-year-old getting infectious mononucleosis in our country. It's unlikely.
Yes.
It's not a very common thought to entertain.
Yes.
Why is it not Wilson? Somebody asked.
Yeah, so we are still debating whether it is primarily a hepatocyte liver disease to begin with. Now, if we entertain a hepatocyte liver disease as one possibility, then the various possibilities will come in, and then we will keep Wilson's also as a possibility.
Absolutely. So right now we are just analyzing the story, and somebody wants to know, has someone documented the distension of abdomen? No, this is on the history.
On
as
the
of
history,
now.
yeah.
So we are still talking on based on the story that we have.
Yeah.
how old is the child?
4-year-old.
So 4-year-old with Wilson's started few months ago. Little unusual.
And one more question: who noticed the jaundice, the doctor or the patient?
The parents.
Parents.
So the point is, if you were to analyze this jaundice, apparently it is conjugated hyperbilirubinemia. Now, if it is conjugated, then we were entertaining a thought of hemolytic anemia when we were discussing the hepatosplenomegaly. Now, for that, getting a conjugated hyperbilirubinemia is very unlikely, or is it possible? Do hemolytics get conjugated hyperbilirubinemia?
It could be in a late stage where any gallstones could obstruct
Yeah.
the gallbladder.
So theoretically, gallstones causing obstruction, but actually we rarely see that in practice. That we see so many hemolytics, but none of them come with gallstone obstruction and obstructive jaundice, right? So therefore, that is unlikely. And similarly, our history so far tells us that this child has been fine. For example, you said you increased appetite. So we don't get any sign of hepatocyte disease. So then also explaining the coming up of jaundice now on that hepatocyte, pre-existing hepatocyte disease is a little difficult. And if that was the situation, then what else would you have expected now? If this child had hepatocyte disease all along, now got jaundice as part of that hepatocyte disease, then what else would you have expected now?
Ascites.
Very good. So that a jaundice would have meant a decompensation of the liver. So then the distension should have markedly increased recently of late, because it would have led to ascites and edema and all that.
It could be that during this 3.5 months he got some medication, and now that medication has caused jaundice. For all that you know, somebody started an anti-TB treatment, and down the line now he comes with jaundice. It's a drug-induced jaundice. So give us a drug history as well. Okay, it's not rare to have such a thing come up, right? For all that we said it may be TB, etc. Somebody must have started anti-TB treatment. So, are you aware what was done for 3.5 months in terms of
Sir,
medication?
I think she said Ayurvedic treatment only in this jaundice or all along?
All along, before, at the beginning of abdominal distension, since then they were...
So, we won't know whether their medications cause jaundice because they cure jaundice. So, I don't know whether they cause jaundice also. So, we don't know that. So, we'll not discuss those, but keep drugs in mind. And for all the, somebody was talking about G6PD now. Could it be that some drug was used and he came out with jaundice? So, all these things need to be assessed.
And now one last googly. Apparently the father has had many episodes of yearly jaundice. So what do you think of that? What are your guesses on that? Or thoughts on that?
Sorry, I didn't miss the history. Every year he gets jaundice.
He's giving history of recurrent jaundice, like at least one episode in 1 year.
And how much is his alcohol intake?
He's alcoholic, that's what I asked. But history of jaundice since when he was 15 years of age. And
started early.
He consumes alcohol. So.
Can it be hereditary spherocytosis in father?
So, yeah, so one of the suggestions is that is the father having hereditary spherocytosis and that's why he gets recurrent jaundice. So your take on that? I mean, it's possible that it's more than recurrent, it's noticed and it reduces or something like that. It's possible, but I would have asked what is the father's general health over this length of time, means whether he's in general keeping good health or he's going downhill. That's one important question to decide what category this jaundice fits into, recurrent jaundice. And then of course other symptoms like is it conjugated or non-conjugated, so whether he passes high colored urine when he gets the jaundice, whether there are any other symptoms associated with that.
There's no history of passing high colored urine, but about the health status I have not asked.
Okay, so no history. If you have asked and there is no history of high colored urine, then first is the jaundice itself is to be questioned whether it is jaundice, and if it is jaundice then something like a hereditary spherocytosis probably stands. So
has the father ever received a transfusion is the question.
No history of PRC transfusion in the father or in the family. So.
I think if I look at the hemolytic jaundice in the father looks unlikely, because why every year just jaundice? Okay, there is no reason why the jaundice fluctuates like this in a hemolytic jaundice. Okay, forget the autoimmune hemolytic jaundice where it starts with fever, gets jaundice, gets better, gets again, but that's not the story. So I really don't know what really correctly mean by recurrent jaundice. The only offside thought was whether he is a G6PD and somebody is giving him antimalarials, cotrimoxazole, sulfur, okay, without knowing what is happening. So we want to know how symptomatic that jaundice was. Any hemolytic jaundice is an asymptomatic jaundice. By that we mean he is not suffering. Any hepatocyte jaundice is a sick child with jaundice. So could we make out all that? So I think we are at this point of time not very sure about what's happening with the father, but we probably doubt what it must have been. The only best judgment is he must be having jaundice all the time, sometimes complained of, sometimes noticed more. Imagine now if he tells you, once a year I get some illness, I go to my doctor, he says you have jaundice. Thereafter I never go to him, so next year he says you have jaundice again. So I suppose he has a jaundice all the time, but only noticed once a year. Okay, but I don't think that is making us wiser in terms of this child's illness. So we'll keep it away for a while.
Yeah, and we have input from an inside source who says that the father is a great masquerader, should not be believed.
Yes, I suppose so, though we will start believing everyone. Don't you believe me for a while? Yes. So I suppose we will give benefits of doubt of believing everyone and still try to make out what best it can. Yeah.
How deep was the father's jaundice?
Sorry.
How much was the jaundice deep in father's case?
No.
No idea. It can be a Dubin Johnson also.
Yeah. In fact, that's what sir was saying, that hereditary spherocytosis or something like an enzyme deficiency where there is a constant low-grade jaundice without any other symptoms, and it's just noticed periodically and is taken as recurrent. So that's a possibility.
So someone wants us to check the father's spleen, but I think first we should check the baby's spleen.
Yeah, first we'll narrow down our differential on the baby and confirm with the father if we think of HS.
Yes.
So
I think this exercise tells us what all questions in the history we must be asking. Okay, we have discussed so many things. Okay, the history should be that in details, and I think we are just learning how good the history can be to make a final diagnosis almost. When you start thinking, you know, oh, I could have asked this and that as well. So that is what it is. Let's see how it is.
इसके मतलब काबिल मतलब मालूम पड़ता है कि आयुर्वेदिक से होता है। पहले ही मुझे मालूम था कि आयुर्वेदिक होता है। वो तब मैं जब अपना ये काम करता था, मैं फील्ड जॉब करता था, जब फील्ड जॉब में मैं मतलब बड़ा पाव ये खा लिया तो उससे भी होता है ना जॉन्डिस। मेरे बात करें, आप बात कर रहे थे फादर इज फादर बीमारी इससे कनेक्टेड है क्या? ऐसा नहीं, हर साल होता है, मतलब हर साल होता है। ये तो मतलब काबिल का मैं अभी इधर जान चुका हूँ कि काबिल सालों के एक बार हुआ तो बाद में होता नहीं, अभी मेरे को मालूम है।
नाही बघ, आम्ही काय डिस्कस करतोय, असले कुठले रोग आहे जे वडिलांमध्ये असू शकतात ज्याच्यामुळे कावीळ होते, आणि तसला काय रोग मुलांमध्ये होतो का, तेच आम्ही डिस्कस करतो. आम्ही तुम्ही जे म्हणताय
मी तेच त्यांना बोललो, माझं पण रक्त टेस्ट करा, म्हणजे मला कशामुळे ते काय होतं
करूया.
मला पण थोडं माहिती.
हो तुमचं ते दोघांचंच निदान करूया ना. आम्ही काय शंका नाही करत की तुम्हाला कावीळ आहे की नाही. आम्ही विचार करतोय की असला कुठला रोग असेल ज्याच्यात तुम्हालाही कावीळ असते आणि बाळालाही असते. तेच नाही तेच करू ना, करून तुमचं पण करू आणि सांगू तुम्हाला. हा, कम एनीवन वुड लाईक टू एक्झामिन? बसा, तुम्ही एक चेअर घेऊन बसा इथे जवळ. नाही, हिला राहू द्या, तुम्ही चेअर जवळ घ्या आणि बसा. एनीबडी वुड लाईक टू एक्झामिन? कम क्विक, कम ऑन, व्हॉलंटियर्स. Good, very good. One person from this side. Come, anybody? Yeah. Tell us your findings quickly. You would like to talk on, okay, just 1 minute. Would you like to talk on general examination first?
So the child is sitting comfortable. The child is comfortable, well nourished, and icterus is present. There is abdominal distension that is present.
So what is the interpretation of what you have observed in general? From how will you connect it to the discussion that we were having on history?
So since we were suspecting a hemolytic disorder or a malignancy or any other disorder in the kid, a malignancy would usually have a cachectic child. Infection would have a sick child, which the kid is not. The kid is icteric. It could be hemolytic, and hemolytic faces It's not very prominent.
Good. So you're looking for a hemolytic phases which is not there. What about chronic liver disease?
Signs of liver cell failure.
More than signs of liver cell failure which you'll examine, but growth itself you said na, that she is well grown. So even chronic liver disease apparently seems less likely. Okay, fine. बेटा एकदा पोट बघूया हाँ 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 अच्छा अच्छा comment on inspection.
So the abdomen looks distended and it's equally distended throughout. There is no local bulge as such seen. The umbilicus is central, not stretched. There are no scars or sinuses present. There are no dilated veins seen.
If I ask you just by looking at this abdomen, tell me whether it is due to fluid or due to other reasons. How will you tell me? How will you answer whether this distension is due to fluid or no?
Flank fullness usually suggests fluid accumulation and transversely stretched umbilicus.
Excellent. And both of that are not there. Anything else?
So dilated veins.
Anything else? Where is the umbilicus? Position of the umbilicus?
It's shifted downwards.
Suggests what?
Some organomegaly.
In the upper half of the abdomen. So therefore all these reasons, just by inspection you can say that there is no fluid. Okay, please palpate. Meanwhile, you tell us on general examination any other positive findings? Speak in the mic nicely. Your mic is not on.
Anthro-wise also her weight for height is more than median, so she is...
Tell us the height, weight.
Height is 88 centimeters, which height comes under less than -3 standard deviation. Weight is 14 kg, which is between -1 standard deviation and median. Weight for height falls more than it's normal. Comes under median. The mid-arm circumference is normal.
Okay. So any thoughts on this anthropometry? Height is 88 centimeters for a 4-year-old child. Normal or less?
Yes.
88 is for what age? 2 years. And weight is
14 kg.
14 kg. So that's weightage is 14 kg is a weight for what age? 4.5, 2.5, 3 years. So weight is that of a 3-year-old, height is that of a 2-year-old, and she is 4-year-old. How will you interpret that?
It can be a chronic because weight till 3 years of age, till 2 years of age, both height and weight were apparently normal. After that, there might be some retardation or stunting.
So in which diseases height is only affected and weight is not affected?
The normal weight could be a pseudo or false sign in such a case. The weight in such a child could be a pseudo or a false sign.
Okay, so she is suggesting that the weight may be misleading.
But there is no fluid.
There is no fluid. If at all, there is just organomegaly. So your 88 is correct? Are you sure of your 88?
No, I'm not very sure. Okay, it can't be 88. If somebody has a thing, because 88 will mean a short stature, and we'll discuss something totally different. Okay, to look at it looks bigger than 88 to me.
No, and so first of all, we just by our eyes we question the 88.
Yeah, we are not questioning the tape. Our eyes can't be as good, but still there is a suspicion.
But
Okay, we need
if
to
at all it is that 88 and the weight is good, then one is, as they said, look at any wrong reason misleading for weight like edema, which is not there, in which case that height has to be constitutional. It cannot be due to a systemic disease.
So there is no tenderness. Liver is palpable, 7 centimeters from the subcostal margin in the mid-clavicular line. It is soft to firm, rounded margins. The left lobe is palpable. It has a span of 12 centimeters. The spleen is also palpable, 3 centimeters from the costal margin along its long axis. There is no free fluid that is appreciated.
Any other positive findings on the abdomen?
No, sir.
So tell us, what is your...
What about pallor? You said, is the child very pale?
The child was pale, and at the time of admission, the child has received one PRC transfusion.
Okay, so now after examination, what are your thought processes and how will you correlate? So what are our positive findings? We have a normal growth and we have icterus and we have hepatosplenomegaly. That's it, right? And pallor, you said on admission which a PRC transfusion has been given. So now what are your thought processes?
So could be
So go systematically, don't just jump to the final diagnosis. Analyze. How will you describe the whole process? Use 3-4 sentences to use adjectives to describe the situation.
4 years old female child with 4 years old female child with hepatosplenomegaly, with icterus, without ascites or no signs of liver cell failure, with anemia, could be suggestive of some hemolytic, with normal growth.
Okay, so what kind of hemolytic? Congenital or acquired?
It could be an acquired hemolytic anemia.
Like?
It could be autoimmune.
Okay, so autoimmune hemolytic anemia. What else? Why not congenital? So again here that height reading is extremely important. If that height reading is really short, then it's a different issue, and if it is not, then it's a different issue. Okay, any other thoughts?
Since the father has been complaining of jaundice as well, and the kid gives history of 4 months of abdominal distension, it could have been that the organomegaly was present from before and has manifested since 4 months, and with icterus, with anemia that required transfusion. So it could be most likely a congenital hemolytic disorder that has manifested now.
Yeah, but congenital hemolytic disorders we discussed, no, either they manifest very early. They don't kind of wait till 4 years to manifest, no?
So if the father is a sickle trait and the kid is also turns out to be a sickle trait with some overlying infection causing anemia.
So do you think sickle trait is causing disease, jaundice in the father repeatedly?
Could cause.
Why should sickle
Would
trait?
not manifest as an abdominal distension itself.
Anybody else? Any other thoughts?
Storage disorder.
Very good. So storage disorder. Which storage disorder?
Glycogen.
Okay. So means what I thought is that the basic concept that we were discussing on history, that this seems to be a reticuloendothelial involvement of the liver and spleen, that jaundice is a spinner. I can't explain that just now. But if we think of it as a reticuloendothelial involvement, then we discussed hemolytic, and one of the possibilities should be discussed as a storage. Is it a consanguinous?
Non-consanguinous.
Non-consanguinous. Sir?
I think all that I can say is that this is not a liver disease. And the reason is that liver is not pathological. This liver is soft to firm, not much enlarged. So this, to begin with,
So
we
liver
must-
liver is firm actually. She said soft, but it is firm and it's enlarged.
What attracted my attention was that liver and spleen are not so large, but the abdominal distension is out of proportion. I thought from a distance that there will be a large liver and spleen to look at. Abdomen looked very distended, but the liver and spleen is not that big. So then why is the abdomen so distended? Is there anything else around that? That's one. Or it's only a gaseous distension for a while now, and maybe tomorrow morning you will not find so much of distension. That may be a possibility. But this liver is not so large, the spleen is not so large. Even then, the abdomen looked very, very long, much distended. Now that we know that this child had a severe pallor, okay, which required a transfusion, there's no doubt that this is a hematological disease. We'll have to explain everything on a hematological disease because there is no liver disease. Plus, this child has done well in weight. If the length is correct, then short stature indicates a chronic hemolytic anemia. So you have one clue that yes, child of chronic hemolytic anemia has a short stature, and this child is a short stature. So I would say then he has a chronic hemolytic anemia. The question is, why is he having jaundice now? Okay, so that I think remains unexplained. Again, like the father, we don't know why every year he is having jaundice. So yes, we have some issues which are not clear. And I think that's where probably some depth in the history could have given us some clue. Not necessarily, he may not know enough. But one thing is sure, looking at her, two things are prominent. Abdominal distension out of proportion to liver and spleen. And the second is, if your measurements are right, then that's a chronic hemolytic anemia. But by then she would have had some facies too. And to that extent, it's a chronic, slowly progressive hemolytic. Not like a thalassemia major which progresses so fast because the RBC life is so small. So spherocytosis can just do that, but provided jaundice has been even seen earlier. So here I think we are not sure looking at it, and we have lot many things. You confidently said there was a high colored urine. Now we are discussing a hemolytic anemia. So again, this tells us that when you get a story of a high colored urine, you need to be sure what does high color means to the parent. You must ask, is it deep yellow? Then you will say, no, I think it's a little yellow. So what is high colored is all right. What is high colored in your mind is the direct bilirubin. For him, any colored is a high color. What is low color? So I think we need to get to all these details. I think such incidences tell us how in depth the history should be, if at all we are going to discuss mainly on a history itself. And I think that is where it is. At this point of time, I am not sure what we are dealing with. If you got a transfusion, then it's a hemolytic disease. But do you have a liver disease and a hemolytic disease? Two things are rare. Wilson's is one where two things are common. Wilson's can have a hemolysis and Wilson can have a liver disease. But this doesn't fit in all those things. And therefore I think we are at a little loss on clinical things. Tell us what investigations have been done.
So this child was developmentally normal?
Yeah.
Development.
See, when you talk about the storage to develop jaundice is a late phenomenon. Okay, if this story is right, that's just 4 months old. Yes, without jaundice, the storage would have come in very much. But storage to develop jaundice would have taken a long time, and therefore that probably is unlikely. Yeah.
So there is a... Sorry.
Unless you finally say that few things are unrelated to each other and we are discussing everything under one umbrella, that's where we are getting stuck up, yes.
There is one comment from the net, and he says that what goes against chronic hemolytic anemia is the normal growth, but we are talking about a child with short stature, so she's not growing normally. That's one point, and the absence of hemolytic facies. Now the hemolytic facies will depend on the degree of hemolysis that is going on, and it need not be present floridly like you would see in a thal major. So these are not against, but we'll have to find out. It's an unusual type of hemolytic possibly.
So complete blood count, HB of 5.8 gram per deciliter, total count of 19,200, platelets of 7,49,000 with hypochromic microcytic picture, MCV of 59.3, MCH of 14.6 and MCHC of 24.7. RDW of 55.8, which is wide. Retic of 2.6%.
Yeah, so one sec. So how will you interpret all this quickly?
It's a microcytic hypochromic anemia with wide RDW.
So wide RDW suggests what?
Anisopoikilocytosis. The variation.
Nutrition.
No, so
Normally hypochromic microcytic with a wide RDW goes most likely in favor of iron deficiency, and hypochromic microcytic with normal RDW in thal trait.
So thal trait. And what happens in thal major?
It will be very wide.
So it will be extremely high RDW. So again, so what I mean is when you say RDW high, you have to specify whether it's high or very high. Because here we are discussing a hemolytic anemia, we are discussing a thal intermedia type of a picture. So this 55 is high or very high?
High.
High. So it just suggests deficiency anemia.
Would thal intermedia have jaundice?
No, sir.
Okay, go on.
Why are the platelets high?
Exactly, why the platelets?
In case of iron deficiency anemia, because there is microcytic hypochromic picture, the machine could, because of the low size of the RBCs, the platelets could also be counted, the RBCs could also be counted as platelets is one point. And thrombopoietin and erythropoietin share the same feature, so because of that platelet count could be increased.
Very good.
Total bilirubin of 26, direct bilirubin of 2.6 total bilirubin, direct bilirubin of 1.3. Enzymes of AST and ALT 128, ALT is 236, alkaline phosphatase of 1039. Serum LDH of 497.
So what's your comment on bilirubin?
It is direct 1.3 as actually 50% could be both direct.
So it's 50% direct, no?
So it is direct hyperbilirubinemia.
Only a little small rider here is that smaller the bilirubin, it's not an easy investigation to do in a lab. There could be an easy error. Smaller the bilirubin, there could be a little error possible. By logic, yes, it's direct. But we'll certainly keep our minds open because bilirubin is not so easy investigation, direct, indirect, etc. at a very small level. When the bilirubin is high, the whole concept is very clear. Many times one would see some borderline suggestion of a direct bilirubin. It may not turn out to be, So we will be open to all that. Are the ALT, AST normal? SGPT,
No, sir,
SGOT?
they are raised.
EST is
Speak that
128.
again.
AST of 128, ALT of 236.
Okay. So what does that mean?
There is mild elevation of the enzymes. So
Which is more involved?
ALT, SGOT.
What does that mean? SGOT is more than SGPT, right?
No, no.
SGPT.
ALT.
SGPT
So
is involved.
PT is more involved.
ALT is more?
Huh.
Okay. All right. So what does that mean?
Hepatocyte injury.
So there is a hepatocyte involvement probably, yes. All right.
Total protein of 6.9 and albumin of 3.5. So it's normal.
6.9 and albumin of 3.5. So globulin of 3.4. Okay.
RBS of 78 milligram percent.
On the hemoglobin CBC, did you tell us nucleated cells on peripheral smear?
No nucleated cells.
No nucleated cells. And what is Menzer's index?
MCV,
What is it?
MCV upon RBC into 100. It is usually done to distinguish between iron deficiency anemia and thalassemia. So.
Okay.
MCV upon RBC.
What is the corrected retic in this child? You said 2.6% or something. What is corrected retic?
Your retic was 2.6.
2.6. No?
How do you get a corrected retic?
Observed hematocrit upon 45 into the retic person.
Okay, fine. You don't have the
1.3.
1.3 is the corrected retic. Okay.
These are all pre-transfusion sample reports you're
Yes,
talking
sir. Among viral studies, we got
She said alkaline phosphatase is raised. And what else?
LDH is normal. Viral studies, HCV report we've got, it is negative.
HCV.
And USG abdomens,
Why did you do HCV?
pre-transfusions.
Okay.
USG abdomen is suggestive of hepatomegaly with coarse ecotexture. With coarse ecotexture, mild splenomegaly, mild periportal congestion with mild ascites.
Portal vein size, etc. They have not said.
No, sir.
So after the investigations, what is your analysis?
It could be again, might go into.
Does the urine routine show bilirubin?
No, sir. Urine and urine bile salts, bile pigments are also absent.
So urine, bile salts, bile pigments absent means what? Is it important?
In case of infective hepatitis, we usually have this bile salts, bile pigments positive.
So more than infective hepatitis, as sir said, we were discussing whether this bilirubin is indirect or direct. Now, if it was direct, then urine must have bile salts, bile pigments. And sir pointed out that it may be difficult to measure and the various fractions, etc. So on one hand, we are saying it's primarily a hematological disease where we want indirect bilirubin, where absence of bile salt, bile pigment favors, but what is odd is the mild elevation of the liver enzymes, right?
And Rajesh, if you are thinking of hemolytic, then you should have a high retic count, which is normal if it's corrected. So again, hemolytic seems to be out because of that. This anemia may be unrelated.
Yeah. Sir, any thoughts or we?
Well, I think for a simple iron deficiency anemia, there is no reason why somebody has to give a transfusion. Okay, this child at 5.5 chronic iron deficiency would not need a transfusion. This child was not in cardiac failure, I suppose. And so, there is no reason why somebody has given a transfusion in an iron deficiency anemia. So that's my first impression. Second is that there is a significant liver and spleen. You don't get it in iron deficiency, so that part is out. Is it a significant liver disease? To my mind, probably not so. Well, there is some evidence of some liver disease. I don't know whether it has happened now, because the story runs after 3.5 months, fever and jaundice. As we said, are these two unrelated issues? I'm still thinking whether they are little unrelated. If this chronic liver disease becomes jaundice, which means that the liver is failing. And that has certainly not happened, because this child has done well in terms of weight at least, if not in terms of growth or height. So to that extent, this is not a chronic liver disease. The findings may suggest an acute liver disease, and an acute liver disease of not viral A. It could be any other virus. For example, I'm just imagining now that suppose there is some transmission of B, C, etc. and then there is some liver pathology, not necessarily a hepatocyte pathology, then possibly that has shown up. Was it totally a malaria doing that? Okay, this child had some fever, this child had jaundice, and all that fever dissipated quickly. So I think at this point of time we are very, very uncertain what we have been discussing. I would say that the findings suggest an recent liver disease, not of a viral A, but maybe some other infection. What other infection? There was fever. So probably a malarial hepatitis maybe. That may be at the best. And he has an iron deficiency anemia. So malaria can explain liver and spleen. But the story is that it's going on for a long time. Again, as I pointed out, that to me abdominal distension looks out of proportion to that liver and spleen. So I'm a little concerned why that is so. So is this child having totally something else? So I think at this point of time, we have no clarity at all what we are doing. And I'm sure you are also not sure what this child has ultimately. And therefore, except a transfusion, you don't know what next to do. And I hope you have not done anything else at all, because you don't know what to do, right? Yes. So looks like you at the end of the whole story and investigation, and we here after discussion are still not very clear.
There is a question, can it not be non-cirrhotic portal fibrosis?
No. That is a congenital hepatic fibrosis what we are talking about. And that congenital hepatic fibrosis really comes as an extra hepatic, that is pre-sinusoidal intrahepatic portal hypertension. Okay, the liver is very firm. Jaundice is not a feature unless a liver starts failing temporarily. The child is often, therefore, this is very unlikely that. So, but a good suggestion, what the person who asked means that there is a liver and spleen, liver is firm, the spleen is there, why not call it a portal hypertension? And a portal hypertension of not a hepatocyte, but intrahepatic pre-sinusoidal. That's a good suggestion, which we could have also brought in our discussion. So, the man who has said this is right in dissent, but this child has anemia, this child has jaundice, so those things probably go out.
And have you done a electrophoresis on this child, hemoglobin?
Yes, sir, but report is awaited.
Report is awaited, fair enough.
So I suppose we will also await further discussion on this. I imagine so, yes. But have you studied the father also?
Not yet.
No, I think get on the father as well. He is also concerned about what is his problem.
One or two small comments. First of all, I wonder when we will get your maturity, sir. When I walked in today, I thought I'll just take this child's history while we were waiting. I couldn't take a detailed history, but he told me that the abdominal distension disappears in the morning and comes up in the evening.
And you are
now,
showing
sir,
us our clinic in the evening only, so Okay, yeah, I think out of proportion.
Sir, I am just saying that when will we learn to make out that this is out of proportion to the findings?
I hope it's not a sarcastic
No,
thing.
no,
How
sir,
can you-
seriously, sir. Seriously, because when he was telling, he told me two things. He's also told me that the appetite is very good. And I was racking my brains that what is this? I didn't get a time to take a full history, but what 3-4 things I got, he said appetite is too good. He actually told that. And the fact that the distension reduces. So which means that there is a big element of
Gaseous
other
distension.
distension. And therefore now, because we are stuck, I am saying that, whether this is an unrelated illness, means suppose this is like a hepatitis, which is now getting better almost, then we will have to define that, because sir said that good appetite means after bad appetite, good appetite. And we all know that hepatitis, when they recover, they start eating very well. So whether you can mark that period little behind, 15 days behind, that's why I was asking you whether the onset of jaundice, whether there was a phase when she had poor appetite, and whether this is a unrelated hepatitis which is getting better. I mean, this thought has come because we are stuck at how to explain this.
Rajesh, one last thing. Somebody is very agitated about this. We discussed this, why this cannot be Wilson's. Can you just put those points again for us?
Yeah. See, Wilson's, as we said, is that first we have to decide that this is a primary hepatocyte disease, that to chronic hepatocyte disease, and then we discuss the etiology of that hepatocyte disease as a Wilson's. So here we are discussing that this child has grown well. Her abdominal distension is only 3-4 months, which is, so we have discussed that this is asymptomatic hepatosplenomegaly, so which is like a reticuloendothelial involvement, not like a hepatocyte involvement. And even after examination, we are still not convinced, on examination at least, that there is hepatocyte involvement. So that's why we are not entertaining Wilson's. About a Wilson's getting autoimmune hemolytic anemia and presenting as anemia as well, that is in a far advanced stage of Wilson's, where the original diagnosis of Wilson's will not be in a question.
And the child should be
And
also
of
much
course
older.
the age, so age being 4 years.
Okay.
So theoretically in the book we read that suspect Wilson's in any kind of presentation, so suspect it even in asymptomatic hepatomegaly, because it's a treatable. But these are logical reasons why it seems less likely.
Okay, there's another comment, and which I would like to respond to. He says, which cirrhosis or fibrosis comes with hepatomegaly? In the pediatric age group, all cirrhosis comes with hepatomegaly. It's the adults who have shrunken liver. So we feel a hard, firm liver in a child with cirrhosis, and the hepatomegaly which sir was referring to was extraportal hypertension intrahepatic. That's known as simple hepatic fibrosis. But in the pediatric age group, it's very unusual to get cirrhosis without hepatomegaly. Sir, would you like to add?
I think so. No, I think now what is clear, he was holding some important findings with him. Yeah, he was trying to rack our brains too. I think now it's clear that he is a reasonably healthy child who has an iron deficiency anemia for a long time. Now he has an abdominal distension which could be gaseous. We don't know why it developed 4 months ago, and I think it could be related to constipation, related to any such factor. And in that, this whole story of liver disease is only last few days, where it starts with fever and mild jaundice. That looks like a high colored jaundice. That's a hepatitis. So it's a hepatitis. Okay. In a normal healthy child with iron deficiency, with a gaseous abdominal distension, which could be constipation, there's no reason why she should get gaseous abdominal distension. Gaseous abdominal distension is an intestinal disease, and therefore a chronic diarrhea children have a gaseous abdominal distension. Otherwise, probably constipation. And as he said, constipation is not ask one question, how often do you go to school, various things that he mentioned. So now I think to construct the whole story, it's looked like an acute hepatitis in a child who has got a chronic iron deficiency anemia and a gaseous distension of abdomen. See how we can totally be misled totally into that.
So, but a firm liver with a left lobe also palpable.
Yeah, fine. Firm liver is an acute hepatitis. After all, soft to firm everybody said. And what is firm? any space occupying lesion in the liver. After all, the hepatitis, the liver hepatocytes are swollen. So there is a firmness. Wait for a while, this liver becomes soft. Okay, the child is eating well, so already the liver is getting better. So if we follow this up, it will end up with a very soft normal liver. But this is not a viral A hepatitis, nor viral E, because that's an acute hepatitis with very high enzymes, and therefore this is not viral A and viral E. The question is what it is then. So again you go back and said, is it a primary hepatotropic disease or an extrahepatic disease with hepatitis? Extrahepatic disease like malaria, typhoid, leptospira, etc. In this child, typhoid, leptospira is out, malaria still stands to be there. And if primary hepatotropic is it hepatitis B, C, etc.? Yes, we need to look at that as well. After all, there could be a hepatitis B and C transferred from the mother into this child, and this child is just developing some symptomatology. So we will look at all that, and I would say that I would certainly investigate this child's liver disease in terms of etiology, because it's not viral A and E. And if it's not viral A and E, then it's unlikely it's been.
Sir, you had also brought up drugs, and he's on Ayurvedic treatment since the beginning of distension.
You don't know.
And sir, the cheeks are almost not really steroid, but really good cheeks. Whether that Ayurvedic medicine has an element of steroid is another issue.
Yeah, we don't know. It could be a drug induced. Yeah, it could be drug induced. I'm okay with that. So I think we'll look at all that. Yeah. Fine.
Why should the child have a firm spleen, enlarged spleen?
The point is that if this child has a spleen, that's why I'm bringing in malaria in my diagnosis. Okay. And then if I have nothing else, I would say not all iron deficiency are without liver and spleen. There could be. Okay. Once we know the diagnosis, likely you fit in those typical findings, push it in.
And see, the point is, if you take away the liver, then now that hereditary spherocytosis also comes in. We'll have to look at the father and the child may both have hereditary spherocytosis, which can explain the spleen also. So when you take away the liver, lot of possibilities open up, So we'll have to decide whether this is a chronic liver or this has come up now. That becomes crucial.
In fact, if in the exam, if you diagnose spherocytosis, you must ask the examiner, can I examine father or mother? Because you just palpate their spleen and you have diagnosed an autosomal dominant hemolytic anemia. So it's a good way to go by.
I think two comments which have come in. One was whether right-sided failure could present like this. Well, he will not come with abdominal distension. He will come with breathlessness and such other complaints. And the other comment was she should have koilonychia, platynychia. Correction to that, in iron deficiency you can have, you don't have to have.
Correct.
I think we'll stop the case here, sir.
I think so.
Thank you, Dr. Anita. And our next case is going to be presented by Dr. Pallavi. Dr. Pallavi, this way.
My patient is 22 months old, female, hailing from Chennai, an informant being mother. Came with chief complaints of fever since 3 days, cough and cold since 2 days. 2 days back, patient was apparently alright. Then she started having fever, which was mild to moderate grade, gradually rising, intermittent and not associated with rigorous rash, subsiding with medication. In between fever, child was active, and after 1 day of fever, mother was complaining of that child had cold, which was initially in the form of blocked nose and then having running nose, and simultaneously had cough, which was dry cough, intermittent, and not associated with diurnal and postural variation, associated with increased respiratory activity. There is mother is giving history that child is not gaining weight like other siblings. There is no history of any ear discharge, lymph node swelling, no history of pain while swallowing, no history of Cox or Cox contact, no history of any chronic illness in the child. Past history, there is no history of previous admission in the past, but mother gives history of there is recurrent cough and cold in baby. In every 2 months, child gets sick. That child gets cough and cold. Birth history: mother was ANC registered, received calcium, iron, folic acid, 2 TT injection, and it was a cesarean, full-term cesarean delivery. Baby cried immediately after birth. There is no history of any NICU stay. Birth weight was 2.2 kg, and she started breastfeeding after 2 hours of delivery. Immunization history till booster 1. Developmentally, child achieve all milestone till 1 year. Child achieved all milestone at appropriate age till 1 year, but at present child can stand only with support and walks with support, but can't stand without support and can't walk without support. She speaks full sentences with meanings and can communicate well with parents and other cousins, and she can dress and she can dress well. She can wear shoes. Developmentally, her motor milestones are delayed, but social and skill are not appropriate for the age. Dietary history: she consumes mixed diet with non-veg twice in a week. According to calorie requirement, her requirement is 1100 kilocalorie per day, and proteins are 11 gram per day. But she is taking 800 kilocalorie and 8 gram protein per day. Deficit in 300 kilocalorie and 3 gram proteins. Family history:
Can you just repeat that diet thing? Speak in the mic properly.
Her caloric requirement is 1100 kilocalorie per day, and proteins are 11 gram per day. But child is consuming 800 kilocalorie in 8 gram, which is deficit in 300 kilocalorie in caloric, and proteins 3 grams deficit in. There are 5 members in the family. Husband is watchman, earns 8,000 per month, and mother is housewife. Younger sibling is 8-year-old. Second one is 3-year-old, and this is 22-month-old. Belongs to lower socio-economic class, according to Gopaswamy. Anthropometry wise, her
Wait. So, if I understood you right, the chief complaint is fever, cold, cough for 3 days and not growing well.
Yeah.
That's
not gaining weight.
Not gaining weight is the chief complaint. Okay.
Not gaining weight is on inquiry. Mother is not giving mother is not complaining of weight, not gaining weight. She has come basically for only cough, cold, and fever.
So why do we have to admit a child of fever, cough, cold for 3 days? When you say that the fever is not very high.
She was breathless. She was having. She was tachypneic when she came.
Okay. So what is your analysis of this fever, cough, cold?
It could be. It could be viral infection in a.
Anybody else? Anybody else? What is your analysis of this fever, cough, cold? Come on, fever, cough, cold is not difficult. Or is the most difficult?
So just acute respiratory infection, and as she has mentioned the history of recurrent cough and cold every 2 months, so maybe hyperreactive airway disease with viral infection, became breathless and needed the admission.
So what more details do you want of the previous episodes?
No, there is no history of nebulization. Child.
Okay, one sec. Let's clear this. Okay. History of nebulization has to be given 0 marks or 0 points. Because anybody who walks into any health facility is likely to be nebulized rightly or wrongly. So don't take history of nebulization as a pointer to wheezing or whatever. Okay. So your analysis perfect that just now it sounds like a viral infection, fever, cough, breathlessness, and since there is repeated episodes in the past, so what details do you want?
Was child breathless? Was child breathless every time she had fever and fever, cough, and cold?
Yeah, mother is telling that child gets there is a increased rate of breathing and difficult in breathing. That's what mother said.
In all the past episodes, or
But
most of the past episodes?
Most of the, but never got admitted for that.
Fine, but there was increased respiratory activity.
Respiratory activity.
And she assumed something.
Fever.
Fever, very good. So was there fever in all the episodes or most of the episodes previously? And why is that important?
It was associated with fever.
Yeah?
Fever was there.
In most of the episodes. Why is that important?
Reactive airway need not have fever every time the child.
So in fact, would you like to ask more detailed questions about the fever itself?
So duration of cough and cold, nocturnal cough, how long it persists, is it with fever or without fever, and needs nebulization for the relief of cough or breathlessness.
And what started first, fever or cough?
Very good. So what started first and whether fever was significant enough each time. So basically what you're trying to do in your mind is you're trying to divide whether these are infections repeatedly or whether these are hyperreactive airway disease which may also have mild fever, and an occasional episode is triggered by a viral infection. So the situations are different and you can analyze them based on your history clinically. So which one is the situation here? Hyperreactive seems to be there because you said there is increased respiratory activity every time. There is coughing every time.
Yes, mother is.
Cough is a dominant symptom. What about fever?
Fever was mild to moderate grade.
In the previous episodes.
Previous episodes.
Starts with fever or starts with cough and cold?
Starts with fever.
Starts with fever. So now tell me, why should a small infant like this get repeated viral infections? Or does every infant get repeated viral infections? When should they get, or when can they get repeated viral infections?
But Rajesh, how are you telling us these are repeated viral infections? They can be bacterial also. What tells us?
So answer him whether they are bacterial or viral.
Child was not that sick that she got admitted.
We can't hear you.
Child was not very sick that that time she got admitted for the illness.
Okay, that is one reason. But bacterial any other reasons? Maybe she's taken antibiotics from family physician.
What are her chief complaints?
She had come with fever, cough, cold only.
So what did you say together?
A bacterial infection would have fever, breathlessness, and then followed by
What will it not have?
Cold.
So or it will have only cold, or it will have only cough. But when you say cold and cough, it becomes a generalized disease. That's why it's viral.
It was a dry cough.
You're looking unhappy about that statement I made.
So again, what we are trying to teach or discuss is that please be sure when you talk of cough and cold, and don't just talk of it cough and cold in one breath without really making sure. Because on the other hand, you're telling us that this child is not growing well. Now, if this child is not growing well, has repeated episodes of fever to begin with, which means infections, and if there is no cold really, then we'll have to really decide whether these are bacterial or lower respiratory infections, which is leading to failure to thrive. So, you have, unless you are very clear in your history, you can be on either side of the fence, right? Okay. What about the diet, you said dietary history now, but what about breastfeeding, weaning? Did you tell us all that?
Yeah, she has exclusively breastfed for 6 months, and after started weaning, only child is not gaining weight according to mother, because she has also given the history of bottle feeding. She started weaning with bottle feeding only.
So did you take the history of weaning and find out whether according to you weaning was appropriate or it was incorrect weaning? Is that important?
It's important.
Yeah?
The deficiency, dietary nutritional supplement should be sufficient for started weaning at appropriate age and correctly also.
So you've not taken that part of the history. How will you analyze this child's developmental history?
Rajesh, one hypothesis before that, is it allowed? So somebody says that it is basically a cardiac disorder with which viral infections get decompensated, so the child has problems.
So who will answer that? Why is this not a heart disease?
There is no history of feeding difficulties or suck cycle. Every time if the heart is getting decompensated and settling down without any medication or any admission till date, and there is no visible precordial activity or anything
not
The child
by
is
the mother.
absolutely okay in between the episodes. That rules out cardiac illness.
Absolutely. So the child is normal between episodes is very important, and if a child was such that would get decompensated with a simple viral infection, this child cannot be normal when there is no at rest. The severity is such that it gets decompensated with a viral infection, can't be normal.
But Rajesh, it was a good thought, no?
Wonderful,
yeah,
wonderful.
Because you've gone beyond respiratory infections. Very nice.
Sorry. How will you analyze the mild development of this child? What strikes you in the development?
Motor delay.
Motor delay, or a better word? What did she say exactly? Were you listening exactly to what she said? She said motor milestones also normal till 1 year of age. And after that,
She's not achieved.
no progress in motor milestones. So it is almost sounding like a motor arrest of development at about 1 year of age. And the other social and language and all is excellent. So what do you make out of that?
Local cause.
Very good. So you think of some local or peripheral pathology, like a local
limb deformity,
neuromuscular, skeletal, muscular, something, some problem like that. And what will happen if the child is malnourished?
Motor delay would be there. Predominantly it would be motor.
There would still be predominantly motor delay. Okay. So we'll examine the child. Come. लेके आइए बहन जी. इधर लेके आइए. इधर बैठेगी. आप इधर ही खड़े रहो. Would anybody like to come and examine, please? Come on, let's make this habit of coming and examining and getting over our fear. Come on, one volunteer at least. Nobody? Okay. Tell us your findings.
So, Anthropometric wise, weight is
Please speak
Dr.
loudly in the
Pallavi.
mic.
weight is 7.4 kg, which is falling between which is less than -3 standard deviation. Height is 73 centimeter, which is also less than -3 standard deviation. Weight for height is between -3 and -2. Head circumference is 44 centimeter, which is between -3 and -2 standard deviation. Midarm circumference is 12.2 centimeter.
One sec. You said weight for height is minus.
Between -3 and -2.
So what is her height age? She is 73 centimeters, you said, right?
Length
1 year old.
actually, length.
Nearly
Just
1 year.
under 1 year.
Just under 1 year.
What is her head circumference like?
44 centimeter. So 1.5.
44 is at what age? 1 year is how much? 45 to 47, depending on what was the birth head circumference. So 44 is just under 1 year.
Just under 1 year.
And 7.4
7.4.
for a birth weight of
2.2.
2.2. So what do you think of that weight?
Triple.
So again under 1 year.
Just under 1 year.
So all the three parameters seem to be fairly parallel or constant. So don't just go by one absolute reading and say, less than this, less than that. You have to correlate all three, and all three seem to be
Under 1 year.
means they correlate to the same age, so to say. Okay?
1 year.
Okay. This has to be always correlated with clinical signs of malnutrition. So do you think she has clinical signs of wasting? Look at the mother's build, look at the mother's height. Yeah?
Yes.
Is she looking like a happy child or a sick child?
Happy child.
So correlate everything. So don't just go by a number and say that 7.8, so less than -3 standard deviations. That doesn't mean anything. Okay, go on.
Child is conscious. Child is conscious and cooperative. My tummy was irritable and comfortable on table. Heart rate is 120 per minute in right radial artery with good volume, regular rhythm. Respiratory rate is 40 per minute. Blood pressure is 98/60 in right brachial artery in supine position. Her anterior fontanelle is closed. There is a depressed nasal bridge. Eye ear appears to be normal. Oral cavity, there are 26 teeth. There is no carier's teeth. There is a rhaetic rosary present. There is a widening of wrist. There is double malleoli, and skin, spine, and genitalia appears to be normal. There is pallor. There is no icterus, clubbing, cyanosis, and lymphadenopathy.
Can you come and show the double malleoli, etc.?
Yes, sir.
सॉरी नहीं तो आप एक काम करो, आप ये रख दो इधर, इसको गोद में ले लो और इधर आके खड़े हो जाओ, इधर आ जाओ. So the widening of the wrist is very, very prominent. You can see a Harrison sulcus. The rickety rosary obviously you'll have to palpate, and थोड़ा सा ये पाँव ऐसे आप ऐसा ये हाथ में ले लो. If the camera can focus on this, this is definitely double malleoli that can be seen and of course better felt. ठीक है, बैठो. What else?
Systemic examination. Systemic examination on RS. Air entry is bilaterally equal. There are bilateral fine crepes. Serious heart sounds supposed to be normal. There is no murmur. And CNS, then there is all cranial nerves are normal. Tone, power, reflexes are also normal. Most likely.
So what's your final impression?
This is a case of LRTI.
Speak in the mic.
Case of LRTI in a case of MAM with signs of rickets.
Sorry, case of LRT. Don't use so many abbreviations. We don't understand them.
The case of LRTI in a MAM child, moderately acute malnourished child with signs of rickets.
Okay. So first tell me why LRTI, then tell me why MAM, and then tell me why.
Why not, sir?
Yeah.
So first tell me why LRTI. She's playing. So do LRTIs play?
Yeah, crepes. There are bilateral crepes she's having, and
So what do crepes mean to you? Crepes is a sign of anatomically which part?
parenchyma, alveolar.
So parenchyma or airway or interstitium?
Parenchyma, alveolar.
All of them. So then how will you make out here?
Whether it is early inspiratory, late type of crepes.
Hearing the crepes is a problem. Early inspiratory, late inspiratory is asking for too much. So basically make it simple. The distribution of signs is very important. If you are getting signs bilaterally and all over, then it cannot be parenchymal, because you can't have a parenchymal bilateral all over disease. Correct? So what is all
in
over?
a child who's playing, to add to that.
Yeah. So what is all over is airway or interstitium. This being a short history of 3 days only, it's unlikely to be interstitium. So therefore this is an airway. Okay. So this is, as we were discussing on history, a viral infection in a child which is a generalized involvement of the respiratory system, but which primarily affects the airway. This we already said, it's a hyperreactive airway disease child because of the past history, right? Okay.
And Rajesh, a viral infection can also cause acute interstitial issues,
Yeah.
which will explain your crepitations. Airway disease, you would expect either rhonchi or wheeze or something, so that's how it fits in.
Okay. Now why ma'am?
Anthropometry wise weight for height.
Speak in the mic
Anthropometry
loudly.
wise weight for height is falling between -3 and -2 standard deviation, and mid-arm circumference is also 12 centimeter.
Yeah, so that is where I was trying to tell you that you need to correlate everything. So in general, if a child is malnourished, the child's weightage should be worse than the height age, which should be both less than the chronological age. So this should be the pattern, that weight and height both affected, weight more affected than the height. Okay, this should be the pattern of malnutrition, and always correlate it with clinical signs of malnutrition. So the child should look wasted, the child malnutrition means the child should be irritable or whatever, and there should be other signs. So as we discussed here, I feel that the three parameters are nearly of the same age. 73 centimeters, 7.4 kg for a child who was born 2.2 kg, and head circumference 44, right? Now where is, what more will you interpret in this? In malnutrition, is head affected? Head is spared. How old is this child?
22 months.
22 months. So for 22 months, is 44 a low head circumference?
Birth weight.
Yeah, so we don't know the birth head circumference. Birth weight was 2.2. We don't know the birth head circumference. So what I am trying to say is that whenever you are calling somebody as malnourished based on a single value, try to correlate all three before labeling as malnutrition. Now your last part was what? Ma'am, with what?
Signs of rickets.
Yeah. So now explain rickets in a malnourished child if this is malnourished, and otherwise decide that this is not a malnourished. Yeah?
So blood pressure she said was 98/60, which sounds a little on the higher side.
Yeah, so 98/60 on the higher side. So how do you explain that?
Crying.
Crying child, simple. Pass it off on the crying child.
Renal issue, sir. Rickets.
Yeah.
No, I think Amol has got a point there. He would not just pass it off on a crying child with this kind of a story.
Renal story, having rickets, not gaining weight, hypertension.
There is no history of chronic medical illness in the baby.
We can't hear you.
There is no history. There is no any history of chronic medical illness in the baby. Like got admitted for that.
Did not get admitted, but what they are trying to say is that this baby is failed to grow because of a chronic renal issue. So that's why this baby has rickets, and that's why this baby is giving you signs of early hypertension. So how will you counter that?
Does a child of renal rickets have hypertension? Where is the site of problem in the kidney in a renal rickets?
Tubules.
And does tubule cause hypertension? Why are you connecting the two at all? But can the renal glomerular disease not cause rickets?
Can cause.
No.
Because there
So
is a conversion of vitamin active liquid.
So severe nephritis, for example a pyelonephritis, say undiagnosed, poorly treated, could fire off the entire kidney as well. And a chronic renal failure occurs, that could cause rickets as well. That can have hypertension. But a typical renal rickets is the tubular defect. No, there is no hypertension at all. So this child obviously, again a renal rickets child is a failure to thrive, and a child whose failure to thrive is not a happy child. Nobody is happy when you fail in exam, in a case discussion, anywhere. So I think this child is so happy. How can she be happy failing? So that's not. But my question is, this child has got florid signs of rickets, but the fontanelle is closed.
Answer.
I thought delayed closure of fontanelle is a sign of rickets. Why is this child fontanelle is closed and double malleolus, all Harrison sulcus, bleeding, all signs? Okay. So who will explain how the head is spared in rickets, if you like to say? And there is no frontoparietal busing also. So do you think rickets started after the head grew completely? What has happened? So why is the head not showing signs? Some thoughts on that? This is obviously a deficiency ricket, there is no doubt. History is very typical.
Breastfeeding.
The child started milestones in time, but thereafter did not. What does it mean? That this child started with vitamin D deficiency, developed rickets, nobody treated, then the milestone started regressing. So this story is very typical of a deficiency rickets. Okay. So do you think it's there for hypophosphatemic rickets? Head is spared. Hypophosphatemic rickets, the head is spared. It starts a little later in life. And the story is at 1 year milestone normal, thereafter no. So I would say the rickets started after 1 year and therefore the head is spared. How do you like that?
And it's a girl, sir. And this is a girl.
And it's a girl. So it's a hypophosphatemic rickets. Okay. Rickets all right. Yeah. So what's your comment to that? No, this child has got a widening of the wrist. So has to have started when the child started putting wrist on that. So this child started rickets early. So it's not a hypophosphatemic rickets. It's simply a classical vitamin D deficiency rickets. But then why the head is fair? So then I want to know whether this child has got a small skull, which is hereditary. Is it autosomal dominant microcephaly? Okay, the head is already small. Fontanelle was small. Okay, where is the large fontanelle? So point is that in an examination we are going to be picking up some odd looking features and asked exactly about how do you go about that. And therefore fontanelle close looked a little funny to me, and I said, why is that so? Why should the fontanelle be open in a rickets? Why do you think the fontanelle is open in rickets? There is no pressure anywhere. No? This is pressure. The leg findings are pressure. Costochondral junctions are pressure. Where is the pressure on the head? Why should the head signs come in rickets? Should not come, right? Where is the pressure frontal? No? So the reason is fastly growing bone. So it's a combination of two. Fastly growing bone and a pressure. This is fastly growing bone. Fastest growing bone at that age. So even there is no need of pressure. Still you will find signs. What does it mean? This child's skull has already grown to a potential, which means a small skull. Small skull by heredity. Milestones are excellent. So this child could have a autosomal dominant small skull. I must examine the father and the mother skull to say that. And therefore the skull is small. In that small skull, the skull has already grown well. Initially, when there were no rickets, fontanelle remained closed. And then as the rickets progress, rest of the signs progress. So there are many ways of looking at this child. I think this child obviously is a happy child. We already discussed everything about fever, cold, cough, etc. And I think the most important part of the recurrent fever, cold and cough, somebody rightly put up congenital heart disease. Okay, what was the major difference? A child who is not doing well versus this child who is doing well. If a child is doing well and has repeated colds and coughs, it only means that the child in between episodes is absolutely normal and recovers fast. So only two conditions, either a recurrent viral infection or a hyperreactive airway disease. But hyperreactive airway disease at this age, starting early, is often not a simple hyperreactive airway disease. This child was a small birth weight, so transient wheezing is a rule on this child. So why are we worried about recurrent? In fact, next time you see a small birth weight child or a preterm child, you need to tell the parents well ahead of time that there could be recurrent cold cough. But don't get worried. Every time you don't need hospitalization, you don't need much medication, you just need a symptomatic treatment to keep them well. And they're growing well. So this is the story of a transient wheezer. The next question you could have asked is, how early did this start? Transient wheezer starts very early. A viral infections come a little later. Why should he get a viral infection? It's not mixing with the society. But if he has started wheezing at 3 months, 6 months, etc., then he has a transient wheezer out of a small birth weight. And I think if that is so, next question is the wheezing getting better now? And the transient wheezer starts getting better beyond 1.5 years, and by 2 years, 3 years, he is already normal. So progress of wheezing. So there are so many questions that you need to ask, and without that, examination findings are all common in everything. Examination findings don't differentiate one from another, but a good history differentiates. So this child must be a transient wheezer. If we don't find a transient wheezer in this child, for example, he was born 3.5 kilos, then I start wondering, why is he wheezing? Does he have a GER? Does he have an aspiration? Does he have a congenital heart? What does he have? That means it's much more pathological. And if that is so, he is not growing well. So growth is so important parameter. And in a small child in the history, how do you pick up a growth? It's difficult for the mother to say whether child is growing well. But it's easy for the mother to say if the child is happy. One who is growing well is happy. One who is not growing well is not happy. One who is malnourished is not happy. One who is well nourished is happy. So this child has no ma'am. This child is reasonably nourished. This child is a small stature right from birth, and therefore is doing well on the growth chart at the same centiles. And I think therefore the diagnosis is simple in this child. Transient wheezer, hopefully getting better and better over time, in a child who has got no failure to thrive, but a small stature, which may be constitutional or genetic. Of course, a low birth weight itself has contributed to it. And then on to a vitamin D deficiency rickets. How early these rickets have started? Obviously seen. This child is small birth weight, so must have started with a susceptibility already to develop rickets early. And therefore this child has developed rickets early, but has not progressed further in terms of worsening rickets. If it has started early at say 2 months, 3 months, by now he could have had a florid rickets. But thereafter his growth started slowing down. Initially the growth must have been better on a breastfeeding. Thereafter the growth slowed down, so rickets continued, but the rickets did not progress. Some people called it an atrophic rickets, which means the rickets have atrophied now, and therefore this is an active rickets, but it's not very fastly progressive rickets. And I think that's another thing. How does a resistant rickets progress? Very fast. And I think that's why this must be a simple deficiency again.
How will you prove your diagnosis? How will you investigate this child?
Routine investigation.
Speak in the mic
CBC,
loudly.
Complete hemogram with X-ray wrist, chest X-ray, and
why X-ray wrist only? Why do you take X-ray wrist for a ricket? What's wrong? You could say X-ray any part, but every time you say X-ray wrist.
To assess.
So why X-ray wrist? Why not knee? Knee also will show rickets, no? So is there a reason why rickets X-rays?
Because the carpal bones are there, so bone age we can determine according to presence of the carpal bone. And
do you
also,
need to determine bone age to diagnose rickets?
No, and also sign of rickets like splaying, fraying, and
No. So don't mix up the issue. So first of all, carpal bones will give you bone age, but here you don't need bone age,
yes,
right? In rickets. So
Mm.
that's separate.
Mm.
Now sir is asking that the splaying and all those signs can be seen even in the tibia, no?
Yes.
So why take a wrist X-ray only? Or you don't get splaying in the tibia?
No, sir, but sign develop first or more rapidly in wrist bone.
So signs develop first and more rapidly in the wrist bone. Any other suggestions?
This child is not started walking, so maybe the signs are not prominent.
Okay. So why do we conventionally take wrist X-ray?
Conventionally you give a BCG on the left side, right? Yeah, that's it. I just wanted you to know that, yes, knee is also fine. Okay, there's no reason. When you are saying that the wrist shows early signs, but not early radiological signs. Wrist shows early clinical sign, but much before wrist, the costochondral junction show the sign. But radiological signs are coming all over equally. Okay, any bone could have been taken. Okay, it's easy to hold a hand more than leg Okay, so there is nothing, it's just a convention. Okay, if you give a BCG on the right side, it will still take up. But everybody gives on the left side so that you and me can see whether BCG scar is seen. Older days when smallpox was given, smallpox scar left behind. So some high socially elite people used to give on the sole, so that only the floor sees it but nobody else sees it. So I suppose, yes, but by convention, yes. So there's no reason. You could have said take any bone if you like.
Why so many X-rays, Rajesh? Why chest also? Why wrist also? Why are we doing so many X-rays? And why are we not doing biochemistry before we are doing X-rays?
I was about to.
Do we have to pay for biochemistry and X-rays are free? Means what's the logic?
So tell us why X-ray chest and whether you want to do any other tests.
Serum
But
calcium.
suppose this child's biochemistry was done and alkaline phosphatase was low. Child has rickets. You did X-ray first, as he said, and then you went for the biochemistry. Alkaline phosphatase is low. And I did it at, say, 6 months of age. I didn't do it at 22 months of age. Do you get that? Any clue? So in which rickets the alkaline phosphatase is low? That's a question. Hypophosphatasia. It's fatal by the end of 1 year. Therefore I said, no, I would have done it earlier. Yeah.
Serum calcium,
Speak
calcium, serum alkaline phosphatase, serum inorganic phosphorus, if possible PTH levels after this.
Why PTH levels?
Maybe raised in case of vitamin D deficiency rickets.
Speak in the mic loudly. So you want to demonstrate secondary hyperparathyroidism.
Yes. Again.
Would you like to do vitamin D levels?
Yes.
And what do you assess in vitamin D? Serum vitamin D levels, what?
Which component?
D3
20.
But
I thought 125 is the final product. Yeah, 25 is not the final product. 25 OH is just the liver. 125 dihydroxy is the final product. Why should I not do that? Why do 25 OH?
25 gives us the stores of vitamin D, the overall.
I don't want to see the store. Sure. Okay, should I not see the final product? 125, not 25 OH.
What
It's
is
125.
the half-life? What is the half-life of 120?
Short half-life.
Short
125.
half-life, yeah.
So 125 is a very transient thing in the blood, and that is why you're not going to measure that.
And 25 OH is low. Only diagnosis is of vitamin D deficiency. In all other kinds of rickets, vitamin 25 OH is not low. 25 OH low means there is no other diagnosis at all. But 125 OH low or normal could have many other possibilities. Therefore, you always do 25 OH if you want to differentiate deficiency from resistance. Okay, that's one. Yeah?
Even mother's calcium levels.
But sir, the question is, should we do vitamin D levels at all? If we have a clinical diagnosis, we think it's nutritional rickets, why can't we just treat? Why would we do all this?
Fine. I think economy is an issue. In this child, I am very sure it's that. And it's so easy. I'll give vitamin D and show the improvement. Radiological, biochemical. I know it's a vitamin D deficiency. I agree with you. If you want to have a final proof, yes. But who wants a final proof? You said in the earlier patient, iron deficiency without doing serum iron. And we call tuberculosis without AFB. And we call pneumonia without knowing who is causing pneumonia. Fair enough, because to find a further label of diagnosis, it may cost trouble. So that's the reason.
So there is also one study, there is an association of respiratory inflammation and decreased vitamin D level. So decreased vitamin D level can cause inflammation of airway and cause recurrent respiratory symptoms. So could it be because of that? Because rickets is very prolonged in this child.
Very Good thought. The answer is easy. Which started first in this child? If respiratory problem started before rickets, then I won't blame it to rickets. And the rickets has to develop and then start recurrent respiratory infection. So, egg first or hen first. So, you're right that it does.
What is the incidence of vitamin D deficiency based on the levels that you do today in our country? Just gross figure. What do you think it is? It is anywhere between 50 to 90%. So whatever disease you have, you do vitamin D levels is going to come low, and somebody is going to correlate the two. So don't always try and correlate everything with vitamin D.
Yesterday's Times of India gave a headline to say 2 out of 3 children in Mumbai are vitamin D deficient. Okay, and they should have said another third one was not checked. So,
okay, you have any tests on this child, any X-ray especially?
X-ray, I'm not sure. So 3 hours before only he got admitted, we have sent.
Okay. How will you treat this child, assuming there is deficiency rickets?
Along with vitamin D3.
Speak in the mic
along
loudly.
with vitamin D3, syrup calcium, and with dietary advice.
So how much vitamin D3 will you give?
According to STOS regimen, 6 lakhs international unit IM OD, and followed by vitamin D3 supplements like along with syrup calcium 150 mkd milligram per kg per dose.
75 to 150 milligram per kg per day. That's calcium. But STOS is not popular with any endocrinologist now.
60,000 international unit per week for 10 weeks.
Okay.
Once in a week.
Yeah, so that's what you're going to say in your exams, because everyone is not in favor of STOS and they may object. And they may also object to you giving it intramuscular. Why? So when do you need to give IM and when do you not need to give IM?
Orally not accepted.
You can give it orally, but when do you have to give it IM? Vitamin
If
D.
they are not taking properly, there is
So
compliance is not better.
If there is malabsorption, that is the situation where you will have to give it intramuscular. Can I ask one last question? When will you see whether there is a biochemical response? In other words, when will you repeat calcium phosphorus alkaline phosphatase, and when will you repeat a your wrist X-ray, or will you do it at all? Anyone? I know you're feeling traumatized by this.
Sir, after 15 days, after 2 weeks, you repeat a wrist X-ray for see white line calcification.
Any other inputs?
Alkaline phosphatase. Alkaline phosphatase will normalize by 15 days, serum calcium 3 weeks, and 3 to 4 weeks radiologic.
Yeah, so radiology is last, and your first change will come in alkaline phosphatase, which you can do at 4 weeks to 6 weeks anytime. What's the rush? Okay.
But sir, in Nelson, there is a return, there is a line. I mean, white line of calcification you first see on 15 days.
It may be given in Nelson, which does not mean that you will do the X-ray. He's just telling you that these changes do occur. Are you going to base your response on therapy only on the white line or on the biochemistry? Biochemistry, that's it. Let's be practical, no?
I think only when you are not sure whether it's a deficiency or resistant and you are fighting out to quickly decide the two, you do it as early as you want. What he's making a point is that you just want to know that everything is all right. In fact, to a point that you will not even need to. But my question is, when would the deformities disappear? Ever they disappear at all? And if so, they disappear, how long do they take? Parents are worried about that, not your alkaline phosphatase. Parents want to know when this deformity gets better. In a simple vitamin D deficiency, rickets, how long does it take for all these deformities to get better? Some idea, some guesswork, 1 day, 2 day, 1 month, 1 year, so whatever.
So it takes a longer time, maybe few years, maybe 2 or 3 years.
Months. Okay. And at the end of that, it all clears up. It takes several months, depending on how severe it is, but it will take several months. So you will have to tell the parent, don't expect these deformities to disappear. But then how will you convince the parents is better? They don't understand the white line or alkaline phosphatase.
Improving gross motor milestones.
Sir, if a child comes with deformity, do we correct it medically first and then go for a surgical intervention, or first do surgical intervention and simultaneously correct?
Surgical never first. Surgical you need only when the deformities won't get corrected by nature. In a vitamin D deficiency, nature will 100% correct deformities. There is no need for surgeon. In a resistant rickets or a vitamin D dependent rickets, you will first control activity of rickets. Once the activity is fully controlled, if the deformities are coming in the way of locomotion or a function, then only you will correct. Otherwise, you will ask him whether cosmetically it's okay for him to have those bent legs, and if he can run, then I won't even do that. It's a major issue, and therefore first control and then only correct. Otherwise, it will form again if it's not corrected.
Sir, I have one girl. She is very short. Vitamin D, nutritional. I gave vitamin D, and there is growth line on X-ray. But she is too short, and mother was asking, will she gain normal height? But I was not having answer.
No, so vitamin D deficiency rickets cannot cause short stature, no? Means
No,
short.
but how does vitamin D deficiency cause short stature? That is the first question to answer. How does it cause short stature? What is affected?
Epiphysis.
Take the mic.
Epiphysis or
So
not?
what is the reason for short stature? It's your limb
And-
deformities that
Yeah.
cause your short stature. The height is determined genetically in any case. And once the deformities get correct, she will attain her normal height, what her genetic potential is. But it's got nothing to do with vitamin D.
And height depends on vertebral column or the lower limbs. Okay, unless the lower limbs are markedly bent, you don't get the height lower. Vertebrae are not much involved. Therefore, if it was rickets, yes, then it should not do that. Short stature must be some other cause. Yeah.
So the point is that if you have demonstrated a white line and all good, but otherwise you may confuse a spondyloepiphyseal dysplasia with rickets, where the spondyloepiphyseal, okay?
If that is so, then what are the radiological signs? Chondrodystrophies look similar, and rickets look similar. So then, epiphyseal dysplasia, this is also epiphyseal disease. So how do you differentiate between rickets and other epiphyseal disorders on an X-ray? Think about it, think about it. So cupping fraying is all right, but there's something more on an X-ray.
So even in the cupping, so there are three words we use: splaying, cupping, and fraying. Now splaying and cupping may be seen even in the epiphyseal dysplasia, but there will be no fraying. What is fraying? Fraying is those irregular calcium deposition, and that's why you get that fraying. So that won't be there, so that's an important thing to look for.
Would we have those tongue-like projections what they describe in the text?
Of course, there will be other features of the dysplasias, but what I'm trying to say is how these three, we know how we talk of cough, cold, fever. We talk of cupping, splaying, and fraying, but each one has a meaning. So fraying is irregular deposit.
And another is the non-calcified cartilage is not seen. So the distance is wide. When you see a child of rickets, there is a wide distance because some part is non-calcified cartilage. That doesn't happen in any other chondrodystrophy. So small little things need to be taken.
I think we have today overshot by half an hour, Rajesh. So yeah, it's 8:30, and we must thank all our online viewers for staying online so long. I hope you enjoyed the session. We really did. The announcement for the next broadcast, that will be on Wednesday, the 10th of November, from December, from Chennai, 2:30 p.m. onwards, and this will be conducted by Dr. Bala. So you're in for a treat. See you again. Bye.